There you go. There we go.
There we
Perfect.
go.
That's
Great.
it. Thank you.
Yay. Thank you. The Arkansas Delta economy is prominently agriculture. The main cash crop is cotton, and we have a couple of other crops grown, rice and soybeans. Since the nation's shift to urban centers and since the mechanization of farm technology during the past 60 years, the Delta has experienced a significant migration of its population. Such declining numbers have really contributed to a diminished tax base, which hampers efforts in education, infrastructure, community health, and several vital aspects of growth. The region has the higher than national average of poverty and literacy and unemployment. For me, we actually reside in Mississippi County, which is a total of 919 square miles. We have transportation access to the Mississippi River, Interstate 55, rail, port, and airport facilities. Our greatest asset really are people. And Southern hospitality is a way of life. The county has 2 county seats, which means we have 2 courthouses, and we have 2 hospitals. We're kind of divided literally between the north and south for the county. Even though Mississippi County is now considered the steel capital of the South, we have, since the mid-1990s, we have 2 large steel mills and several small plants that support the steel production. Mississippi County still has seen a consistent economic decline since the closure of Ecker Air Force Base in 1992. The economic decline and changes in health care reimbursement have had a huge impact on our local health care system. The hospital system is made up of 2 facilities, a 168-bed acute care facility and a 36-bed critical access facility. they are located 17 miles apart. So for those of you who have know much about critical access, you realize that we were kind of grandfathered into that 35-mile range. The 2 facilities were managed for a period of time by Baptist Healthcare out of Memphis, Tennessee, which is 70 miles south of us. From the mid-1980s till about December of 2004, Baptist was our management firm. In December of 2004, the county leased the 2 hospitals, Blytheville Great River Medical Center and Osceola South Mississippi County Regional Medical Center, to Ameris of Arkansas. This lease also included a 65-bed long-term care facility, home health, hospice, geriatric psych, and an ambulance service. From 2004 until Ameris relinquished the lease in March of 2009, parts of the hospital system were systematically sold or closed. No financial resources were expended on the infrastructure of the buildings, technology, or the betterment of the staff, including education. The 2 facilities were managed as independent, separate and apart. That meant they had separate administrative teams, separate nurse managers. Each had to be a standalone unit and survive financially. Ameris, as each facility declined during Ameris's management, we lost physicians. Physicians dropped off staff, and some left the county. Others simply withdrew their privileges. Ameris's actions created a perfect storm. In March of 2009, Ameris gave the county a 30-day notice of lease termination. County officials found themselves with 2 hospitals, no provider numbers for billing unless we assumed Ameris's, no bank account, and no administrative team to manage the 2 hospitals. So where did we begin? The county worked with the Board of Governors and brought in Quorum Health Resources, or better known as QHR, for the administrative management services, securing a CEO and a CFO for the healthcare system. The CEO set about establishing a shared leadership team for the 2 facilities. What exactly does that mean? Each nursing unit kept their own nurse manager, but all other services have one director who's responsible for services, their department, at each facility. That includes lab, radiology, physical therapy. Plant ops is shared. Clinical support, which is quality, and case management, infection control are shared. So that was a new step for us, trying to share management. QHR sent a team in to evaluate the organization for risk and opportunities. A couple of the areas that came to point were lack of resources and a need for updated education. As we started to move forward, the organization had multiple issues to overcome in the rebuilding process. A lack of financial resources. Ameris had not only closed or sold services, they had taken an advance on a cost report, which is much like your income tax refund, and had not disclosed this in their departure. So the organization found themselves owing $1 million to CMS. QHR had a solid team of experts in the background, but in order to bring those in, it would take financial resources to bring those consultants in because you pay for their travel and lodging. When I say there was a lack of human resources, the two facilities were truly at base staffing. The nursing directors often covered shifts, and sending them out to educational offerings would result in an understaffing issue. Even when we were struggling with the how-to parts, the organization as a whole kept their eyes on a big picture, maintaining healthcare services in Mississippi County. You can see the numbers here, and although this is a quick breakdown of the cost to send one nurse manager to a class in Little Rock, I know it doesn't sound like a lot of money, $500–600, but when you're on credit hold and trying to get supplies delivered, even that small amount has to be truly justified before you can send somebody out for education. So what did we have? Having come from a background of academics where we expanded a traditional associate degree program to a satellite campus 60 miles away using compressed video equipment, it seemed natural to use telehealth equipment we had on site to connect the hospital system with educational opportunities. We had one terminal at South Mississippi County, 3 terminals at Great River, and I was told that the equipment had come to us through some telehealth grants and possibly some disaster preparation funding. The issue with this stuff was that some of the equipment was old. Our best friend became the 1-800 helpline. It was awesome. We never ever felt dumb or out of place calling them. They were always very resourceful. We also quickly recognized that our internet provider wasn't sufficient to do all the things that we wanted to do. When I talk about outdated equipment, I'd been employed here at GRMC in the mid-90s when Baptist Healthcare was here and put in their first hospital system order entry system. While researching a connectivity issue when I came back on board after July of 2009, I laughingly told some of our IT folks these looked like the same Cisco switches we had installed under Baptist. It wasn't a joke when we pulled the switch out and it literally had a BMH sticker on it. We knew then the infrastructure had to be replaced. So we did some research and found out our old carrier was not necessarily our friend, and at one point in the time, because of poor line connectivity and a lack of bandwidth at South Mississippi County, we couldn't operate systems simultaneously. If you were trying to send CT images to a Nighthawk service or scan records into our archival system where the server was based at GRMC, radiology had to call HIM and ask them to stop scanning so that they could send their images, and then HIM could resume scanning. So we partnered with Ritter Communications for high-speed internet. We also updated wiring and some of the infrastructure with switches in the building. And about this time, Christmas came early to us. We got a call telling us that we were in line to get new audiovisual equipment through Arkansas E-Link. Our team during the initial rebuilding stage quickly recognized the need to meet daily. We were experiencing growing pains. Our COO, CNO needed to be in both facilities but needed to be available to the CEO and CFO who are primarily housed at GRMC. We dealt with topics like how do you standardize forms, how do you share managers, how does administration keep directors updated, and how do directors keep admin updated. We began holding morning meetings via compressed video. This meeting started out with nursing. The nurse managers had an opportunity every morning from 8:30 to 9, which often ran much longer than 9, to share their struggles and define where we were going. Seeing each other added a personal touch to the struggles everyone was experiencing. In this meeting, the nurse managers worked on merging policies, standardized forms, and really talked about staffing issues. We sometimes refer to these meetings as our rock-kicking time. Remember, the two facilities were both county-owned and managed by one organization prior to March of 2009. They had been operated as separate facilities. They were even at times pitted against each other, with threats of closing one over the other. Being able to see face-to-face and seeing the struggles rather than reading them in an email or hearing them over the phone helped us build a team. It opened the communication between the two facilities. These meetings continue today. We have added ancillary services to the Monday meetings. This gives everyone an opportunity to share what's going on in their department, ask for help, and offer support to the other teams. Cuts down on our mileage expenses and the time that the directors have to be out of their facilities. It wasn't long after I came on board that we got a call from the Office of Rural Health, and they wanted to know if we'd like to continue our annual fee for continuing education. Surprise, surprise, we didn't even know we had that opportunity. We quickly answered yes, and that's exactly what we did. We couldn't believe the happy dance. Are you would have been surprised to see the happy dance we did when we realized we could have the same opportunity to experience education that UAMS had access to. Nursing directors could attend educational offerings without leaving their facility or having to drive 1 to 3 hours one way to attend something. One of the first opportunities we took was this nursing leadership training. It really was our first taste of how we could learn in the comfort of our own facility. Our physicians, really our pediatricians, we have 3 at Great River, got on board. Every Thursday's Peds Place, they spend their lunch hour learning about a different pediatric problem. The conference is interactive. They have the ability to interact with the speaker. A case presentation illustrating the topic is discussed at the beginning of the session, and the speaker frequently has a written guideline covering the topic, which they can retrieve from the web. We have one pediatrician who she earns all of her CMEs through Peds Place. She's in a standalone practice, and this allows her to minimize the time that she has to be out of her space. Recently, our staff at South Mississippi County, the Critical Access Facility, has started tuning into Peds Place, specifically the ER staff. They've recognized that they don't see a lot of peds and they need to expand their knowledge on pediatric emergencies. We also got a call from the state, disaster services. The 2 hospitals had been awarded funding for disaster preparation. Part of the criteria for being awarded the funding was to participate in monthly regional disaster preparation meetings. The hospital preparedness programs distributes federal funds to the hospital systems so that they can plan and prepare for disaster or public health emergencies in their communities. The goal of the system is to enhance the capabilities of the local healthcare team in response to the needs of the community. Our 2 biggest threats truly are tornadoes and earthquake. We actually sit on part of the New Madrid fault line. Once again, we found that those involved in the preparedness activities wanted to do the right thing, but they lacked the resources or the ability to participate. We met with the state, agreed to meet with the participation requirements if we could use compressed video. Once again, we were connected to experts in the field without leaving our facility. STEMI is a partnership between Methodist University Hospital, local EMS, and us. You'd think that all hospitals treat a heart attack the same way, especially since we're all graded on core measures. This isn't true. The gold standard is to get the patient with experiencing an ST segment elevation MI to a cath lab in less than an hour. And historically, what would happen here when a patient presented to our ED with a STEMI, we'd treat and then start trying to find a place to send the patient. We'd call a cardiologist, hope they'd accept the patient, call a hospital, hope they'd had a bed, call an ambulance or a helicopter. Sometimes this would take us an hour in itself. We used video conferencing to meet during the development of our STEMI program with Methodist. We continue to use it now almost 2 years into the program when we do chart reviews and timeline each activation of STEMI to identify opportunities for us to improve our patient activation of EMS to cath lab time. EMS, local EMS services, and their flight crews are all invited to attend these meetings at either facility, which in the county they're on, and our nurse manager at SMC was recently asked, this program has been so successful, to share our role with the Methodist STEMI outreach program during their accreditation process. We got lucky. Once again, we were blessed to become part of the Arkansas SAVES program, which stands for Stroke Assistance through the Virtual Emergency Support Program. It's awesome. This program connects patients living in Mississippi River Delta with other rural parts of the state and with standardized evaluation or assessment for stroke-like symptoms and real face-to-face access to a neurologist for evaluation and treatment. The program also requires our nursing staff to run mock drills using the equipment and the NIH stroke scale assessment. During the drills, the staff interact with the neurologist. This interaction helps build trust, opens communication, and maintains a level of competency for our staff. Before Arkansas SAVES, much like the patient's experience in a heart attack, a patient would show up with stroke-like symptoms, present to our ER. We triage, assess, get a CT, send to the radiology, get it back, and then we might give TPA or try to find a neurologist or a hospital to accept. Again, the hard part was finding somewhere to send this patient. With Arkansas SAVES, it's a one-stop call. We activate the program, determine the type and degree of the stroke, and then the program assists us with connecting the patient in the Delta with a higher level of care. Trauma. Just as the hospital started to rebuild, Arkansas began a push to establish a trauma system. Being part of the trauma system means that an organization, we can provide a standard of care, rapid response to patients presenting to our emergency room as a result of trauma. One of the best tools an organization can use during designation or certification process is outside resources. Recreating the wheel is hard work, and we already had enough of that on our hands. We looked to those who had already had their wheels on and were speeding along. The Northeast Arkansas Regional Trauma Committee is that resource. We immediately realized that we could connect with other facilities to assist with the preparation process for trauma designation. During our video conference with the NEA track, we would put names and faces together. We could ask questions that needed to be answered and share other issues among people who were having similar process issues. Once during the preparation process, we questioned the trauma gurus in Little Rock, set up a video conference so we could discuss our questions. We were able to keep both the ED directors in their facilities and include the CEO, COO, and CNO in the meeting. Part of the requirement for a Level 4 trauma designation is physician involvement. Our trauma medical director are all working physicians. We use the video equipment in the ER to allow them to attend the Northeast Arkansas track meetings. This allows us to meet that physician participation requirement. Regulatory compliance. Even though we are a rural organization in the Mississippi River Delta, we are held to the same regulatory standards as all other hospitals in the U.S. We participate in programs such as core measures, the Arkansas Medicaid IQI and Patient Quality Initiative, or the National Health Safety Network, HNSN, and Joint Commission. We are Joint Commission accredited. For my quality team, it's a 3-hour drive one way to Little Rock. Being able to participate in video conferences allows us to minimize our time out of the facility and allows us to remain up to date with changes. We also provide organizational education via videos on core measures. Our core measure team meets via videos, safety team meets, risk committee, performance improvement team. We all gather in the boardroom or the classroom and use the video equipment to be able to share information from facility to facility. And we've actually started to run into some scheduling conflict over rooms with the equipment available. Joint Commission, during our preparation for Joint Commission, we held team meetings, and as part of the survey process, we actually held some of our exit interviews by compressed video. This allowed each facility to stay up to date with their sister and know what was going on at that time. One of the biggest, and I guess the one that brings the most joy to us, is being able to keep our moms and babies and provide patient-centered care. We deliver at GRMC approximately 400 babies a year, and a significant number of those come in with no prenatal and are high-risk OB. And we use UAMS and Arkansas Children's to transfer these babies to a higher level of care. Thanks to Angels, we are able to keep mom and baby together. Sometimes these babies leave before mom ever gets to see them, and so we have arrangements in our nursery so that mom can go in and hook up with Children's or UAMS and see the baby. And on the other end, the staff at the receiving facility has become so used and so compassionate to understanding that these moms are literally 3 hours away from their children. They'll pick them up and turn them around and hold them and make sure they can have 10 toes and 10 fingers and they're all happy. It truly is a blessing for us to know that we can keep mom, make sure she's healthy before she gets on that 3-hour trip to Little Rock in order to take care of her baby. So where do we go from here? We really, at one point when Ameris was here, we had the availability to do high-risk OB ultrasounds, but because of a lack of use of services, that equipment was taken out of our facility. And for our OBs to travel 3 to 4 hours, depending on where they have to go, for some of them it's like telling them to go to the moon. Transportation is an issue. So we'd like to have reemployment of the high-risk OB ultrasound in the facility, and we'd like to look at some community education programs. We can envision being able to offer a diabetes education program or some chronic disease management courses using compressed video equipment between the two facilities. Again, 17 miles doesn't sound like a lot, but for some of our patients, 17 miles, again, is like taking a trip to the moon. So the big picture, where are we going to go? Well, we hope to keep growing. We hope to continue to provide quality health care to the residents of Mississippi County and the River Delta. We are truly still in our growth phase. At this point, both facilities are financially stable. The physician staff has been replenished, and we are at a point where we can see light to move forward. I appreciate your time this afternoon, and if you have questions, I'm here to answer.
Yeah, thank you so much, Connie. That was just a great talk. I got a lot of stuff out of that. I've got a question. I mean, let's go back to, I guess your first sort of foray into interactive video. I mean, was that the? I'm looking at my notes. I mean, was that the STEMI? Was it? I mean, was that the STEMI project?
As a group, I think our really first thought was one morning some of our nurse managers said, we can't quite make that drive today. We've got this, and this going on, and somebody said, grab the video equipment. Let's see if we can connect, and that's literally started our meeting process.
Right. If anybody else has any questions, we've got, the floor is yours. If you see on the control panel, you can ask questions and you can type it in, and then it shows up on my screen. So if there are any questions. Okay, I've got a question. Let's see. The person says, give us an idea of how many consults are done using the equipment.
I would say we probably 2 to 5 a month, depending upon where you're at. One of the ways that we use consults is in the nursery. If we have a baby, a bad baby, we used to get UAMS. The pediatrician would get them on the phone or get children's on the phone. Usually it's children's. Get children's on the phone. And now, instead of getting children's on the phone, we can actually position the baby near the equipment, and the neonatologist, children's can see the infant at the same time we are for the assessments.
Right. Okay, let's see. Let me scroll through my... And yeah, one of the question asked, I think we got that. You answered that. The South Mississippi County Regional Medical Center is part of the Arkansas SAVES program, correct?
Yes, they actually just came on board maybe 2 months ago. They finished all of their training, and we are really, really excited about that. The excitement comes with our county is long in ground, and so if you're on the far end of the county and you needed a response for stroke-like symptoms, to get to Great River, you would pass South Mississippi County, but that could be up to a 45-minute ride via ambulance. Right. So, yeah, we're really excited. South Mississippi County is now part of Arkansas SAVES.
Okay, I've got another question. What's been the largest roadblock with this, the largest roadblock with this project? Equipment, physician pushback?
Equipment, when we first started, our biggest roadblock was having the infrastructure to be able to operate the equipment.
Okay. And so just training. Is that? I mean, you just say.
It was actually the building had some of it was the wiring in the building. The switches were so old. Just the overall infrastructure of the IT system, and then originally, during the Ameris decline, we lost a lot of talented employees, and so our IT folks that were left here, although were talented at what they did, had not had much exposure or much use to even call to be using the equipment. So there was a learning curve on the front end.
Right. Okay, I've got another question. Can you share the financial model for those in your network? I mean, like, I guess that one is more. I mean, I don't know if. I mean, that's more of a. I guess you're on the Arkansas eLink network, right?
Yes, we are.
Yeah. So. Let's see. So, all right, here's one. What new ways would you like to use telehealth? I mean, are there any other, is there any other demand, that you can see that you can use it for?
Community education.
Okay.
That's our next biggest push is community education. And possibly looking into some of that 72-hour readmission that's coming down the pike towards all of us on reimbursement.
Right.
In the rural area, in Mississippi County alone, there are no diabetic educators, certified diabetic educators. And there are very little educational offerings for someone with a chronic disease process like congestive heart failure. You get a little in the physician's office, but you don't get enough for a patient to manage their disease process at home. So we'd like to be able to offer those type of classes, and it may be that we only have one person, but we could offer the classes at both facilities to minimize the public's need to drive. Okay,
yeah, I mean that actually just answered a question about that someone had for patient readmissions with who have chronic diseases. Okay, let me see. I've got another question here. Have there, have there been any further developments in the focus on telepsychiatry and mental health treatment in your area?
No, and that is a huge void in healthcare, particularly in rural Arkansas.
Yeah, I can say, I can kind of say that there are programs here that UMS offers, and I'll hang on, let me pull that up, and I can share it. But in the meantime, we'll take another question. All right, hang on, still coming in here. Okay, what about the training on telemedicine for paramedical staff like radiographers and the like?
When the organization was part of the Angels program with a high-risk OB ultrasound, they provided all of the training for our staff. And that was prior to me coming on board. But I understand that training came straight across. And I have to say that you guys at eLink have been absolutely awesome about offering us training on the equipment and getting us up and moving.
Thank you. Yeah. Well, let's see if are there any other questions? Let me see if we have any other questions. Okay. Are you utilizing the equipment for mobile crisis or any of the behavioral health stuff? I think we had a similar question there, but
No. Again, mental health is a void in our county, and within our hospital system, we don't really offer mental health services, and that's just one of those areas that we if we could use telehealth to address would be awesome.
yeah. Okay, question asker, how many times per day do you think you use your telehealth equipment?
Anywhere from 3 to 5.
Yeah, wow, I mean, that's really quite often, yeah.
Yeah. At first we were a little hesitant, and those that primarily use it are our nurse managers. They have really embraced the technology, and I have to say they're a great group to work with. They'll pick it up now and use it on their own. So that's been really beneficial to us. And at first we didn't have trouble scheduling rooms. Even now we have a little trouble sometimes with making sure everybody can get to the equipment they need. And that's a good thing.
Right, right. Okay, we've got some time left for some other questions. If we could, anybody wants to. Okay, question just came in. What about burn? Are you using it to consult your burns at Arkansas Children's Hospital?
We are in the process of beefing that up a little. We know that we have the ability. We've not had an occasion to use it yet.
Okay. Let's see. And yes, I'll just remind everyone that we are recording this session, so it'll be available later in the week. One question comes in, is Connie willing to be contacted if we have any question? I mean, I don't know if you want to share your email or just share a phone number.
I can.
Okay.
I can. My direct line is 870-838-7394.
Okay. Hopefully everyone got that. Okay, let's see. I mean, another kind of similar question, could this technology possibly be used to help with patient readmissions for chronic diseases? And I know you mentioned that was one of the things you were wanting to sort of expand into, into what you guys were offering.
I do. I really think that education and surveillance are the two key factors in minimizing hospital readmissions. And surveillance, I can't quite grasp how we could do that, but the education component we could certainly do by compressed video and be able to share resources with other facilities.
Great. Okay, let's see. I've got one here. This person says, I work with a new company that is focusing strictly on providing telepsychiatry to rural settings in Oklahoma. It seems most states are also lacking the needed providers in the rural setting. Thanks so much for sharing your statistics information.
Yeah.
Yeah, so another sort of shortage, as we get out into the rural areas. Psych. Okay, any other? Any other questions? We've still got a few minutes. My apologies for taking so long. Having a difficulty finding the question here. Okay, question here about, everyone's always curious about the the reimbursement and compensation. So can you share how you are compensated for the consults?
Um, let's take, for instance, on the OB high-risk ultrasounds, we can actually bill for the procedure, but we can't bill for the professional component. That comes from those on the other end who are actually reading the read. So the billing for the service brings in extra procedure bills.
Okay. Does your site work with any other local providers? Other than the the other site that's in your network. But are you connected with any other sort of local providers like nursing homes or anybody like that?
Not yet.
Yeah. Well, I was just curious. A lot of people ask that question. So, okay, I'm trying to navigate this list and. Okay, so this question asks, since you're a part of the trauma system, do you feel you'd benefit from consults from physical medicine and rehab? So, PMR type doctors via this equipment. So, is that something that would be useful?
You could, for us in the trauma system, being able to share particularly orthopedic injuries with an orthopedic physician before we transfer them. What typically happens is our ER doc would look at an orthopedic injury, a fracture of some form, and we would really start to look for a place to send that patient. Well, sometimes the patient would get to the med in Memphis or over towards Jonesboro, and only for the orthopedic doc to take a look at it and say, I can see you in the clinic in a couple of days.
Yeah.
Well, then the patient's traveled 70 miles and has the expense of the transfer. So being able to share images as well as real-time physical assessment of the patient or visual assessment of the patient is beneficial. It will help us minimize those transfers.
Great. Okay, let's see. Scrolling down the list of questions. If there are any other questions, now's the time. And I really appreciate your patience, Connie, in taking all these questions.
You're welcome. We've been on the other end with lots of questions as we've grown through this
Sure.
process.
No, it's okay. I'm scrolling. I don't see anything new. Well, all right. Well, why don't we go ahead and wrap it up here? I appreciate you giving us your time, Connie. And what we'll do is we are recording this, so we'll try to get it back out and make the file available over the next couple days. So just look for that on LearnTelehealth.org. It'll be there, on the home page. And if there's anything else, and otherwise, we'll go ahead and sign off.
Thank you.
All right. Thank you.